Okay, we're going to progress on to step 4, which is our advanced airways. So again, we're looking at supraglottic airway and endotracheal intubation. If the airway is compromised with vomitus that cannot be cleared, or continuous vomiting, cannot be cleared with suctioning, or if the resuscitation has gone past 660 compressions with no VFib present. If these two criteria are met, you will progress to supraglottic or to endotracheal intubation. The intubation must be performed by the most experienced in successful intubation paramedic on the scene, or it must be performed by the paramedic with the most experience in intubation and successful intubation that is on scene. Meaning, if there's somebody more experienced on the service but they're not on duty that day, of course you're not going to call them in. You're going to apply O2 at 15 liters per nasal cannula prior to and throughout the intubation attempt. Again, this is to help prevent hypoxia through the intubation attempt through passive oxygenation. We are going to continue our end-tidal CO2 monitoring before that first breath into that ET tube as well. We should have been monitoring end-tidal CO2 through any kind of bag mask ventilations. We are absolutely going to place an end-tidal CO2 adapter to our ET tube and bag mask, or our bag valve, to monitor that first breath going in through end-tidal intubation. Not only is it going to give you the indicator of your patient's condition, breath to breath, it is also going to confirm that that tube is placed in the proper location in the trachea as well. If the ET tube displaces and is removed, it is no longer effective, then we will replace that with a supraglottic airway. This is a quicker airway to resecure than to take the time and reset up to place a endotracheal tube.